Yeah, we'll make a start now. So thank you everyone for joining us today. I want to welcome you all to this webinar, which is about informing health benefits package design using evidence on opportunity costs. And this is the fourth and final webinar in a special series that HITAP, the Health Intervention and Technology Assessment Program in Thailand, are co-hosting together with the Center for Health Economics at the University of York. I'm Jessica Oholic from the Center for Health Economics, and I'll be your chair today. So before I introduce our experts, I'd like to go through a bit of housekeeping. So first point of housekeeping is that the webinar will be recorded to prepare summaries. So please mute your microphones unless you're speaking. We're going to save all the questions until the end of each presentation. However, you can ask a question at any time by writing it in the Q&A chat function, and we'll save these to be answered during the Q&A at the end. During the Q&A, you may also use the raise hand function to show your interest to speak. So each speaker will speak for about 10 minutes, followed by about 10 minutes for discussion from Professor Anna Vassall, which should leave us plenty of time for Q&A. We will finish at 1:15 on the dot. So now that that's all out of the way, let me introduce our speakers and the agenda for the day. So we have with us Dr. Emmanuel Odame, who is Director of Policy, Planning, Monitoring and Evaluation of the Ministry of Health Ghana, and a doctor by training, and holds a number of board memberships as well. He was the technical lead for the development of the Universal Health Coverage Roadmap 2020 to 2030 for Ghana, and is also the focal point for universal health coverage and sustainable development goals in the health sector. He is a steering committee member for UHC 2030 based in Geneva. We also have Dr. Pamela Gongora Salazar, who has been advisor to the Health Minister of Colombia, lecturer at Universidad del Rosario in Colombia, and is currently a consultant for the Inter-American Development Bank whilst undertaking DPhil studies in population health at the Health Economics Research Center at Oxford University. Ms. Sakshi Mohan is a research fellow at the Center for Health Economics, where she works with the Tenzi Laonse project on adapting economic evaluation methods to inform policy decisions in healthcare resource allocation and database solutions for the optimization of healthcare delivery. She has worked as an economist at the Ministry of Health in Malawi under the ODI Fellowship Scheme, and as a research assistant at IFMR Lead, an Indian nonprofit organization. Finally, Professor Anna Vassall is former director of LSHTM's Center for Health Economics in London, and is currently co-director of LSHTM's Global Health Economics Center and executive director at the Amsterdam Institute for Global Health and Development. She has been a member of a number of WHO programs and task forces, and has led a wide range of influential economic research on priority setting, costing, poverty and economic impact, financing, and economic evaluation. Among other projects, she currently supports several countries in developing health benefits packages as part of the Disease Control Priorities Project and International Decision Support Initiative. So it's a delight to have this wealth of experience among our speakers. And so without further ado, I will hand it over to you, Dr. Odame, to start.
Thank you so much to all the speakers. And also thank you so much for our facilitator for this very important topic at this point in time. So our study was on the economic evaluation, looking at the National Health Insurance Scheme in Ghana, and currently ongoing discussions on the benefit package and what will inform us. So this work was done by myself and Elinvele Cook, who was an ODI fellow then working with me in the Ministry of Health. We had a lot of support also from Professor Jessica Ochelaga, who want to acknowledge our support. And actually, this work was based on the work they did in 2018. The methods were adapted from that. Next slide. So in Ghana, we had our national health insurance set up in 2004. But since then, we had a lot of financial deficits since 2009 because we didn't have an explicit benefit package. It was more implicit, covering about 95% of disease conditions with no health technology assessment done around them. And we are also seeing increasing share of out-of-pocket costs currently, and it's even evolving now. As I'm speaking to you now, there are increasing worries about financial sustainability of the scheme and their ongoing calls for reforms. So this work was to feed into that conversation on the ongoing calls for reforms and to drive a reform that will be more evidence-based to inform decision makers on how best we should go around it. Next. So we thought through looking at the cost-effective analysis concerning the National Health Insurance Benefit Package to first of all provide a piece of evidence, like I said, in the ongoing reforms and educational resource planning for some of our HTA methods. Next, please. So in terms of methods, we realize that a lot of the work we've done, a lot of this work, look at opportunity cost of the interventions, but which comes in quite handy, looking at the net health benefits, total population, look at the opportunity costs. So look at each of those interventions, we consider both preventing and creating treatments, and then based on data from the Ghana College of Physicians and Surgeons, and also looking at the One Health tool, where we pick some of the costs in the National Health Insurance Scheme population manner, which we could not use fully. Because of data gaps, we could only analyze about 70 interventions, and others were excluded. So for each intervention that was costed, we used bottom-up approaches. So we had the HR data of the Ministry of Health, where we could pick all the payroll data to look at the physician time and costs. Then we looked at the drugs. We have a thyroid list in Ghana, the National Health Insurance thyroid list, where we could not get the types covered under schemes. We also looked at some wholesalers where we could pick up some costs and some health facilities. We looked at the consumables, wholesalers, procurement departments, also their inpatient base. Then in terms of the population base, we use data from the Ghana Statistical Service, the global budget of this study, and also a lot of economic literature. So basically triangulated across all the databases and coming up with the cost items. We also relied a lot on subject matter experts and technical experts like real experts. Next please. So we need one measure of how that we could compare with all the other interventions. And the globally used measure for the disability adjusted life year, which is more common in low middle income countries. So we based on it, which accounts for the years of life lost, the years of life lived with disability. And then went a bit more into the data in the TAF Global Health Cost Effectiveness and Registry, Analysis Registry. So in all this, we could look at the net, we took a closer look at the net health benefits, which is a very good measure of cost effectiveness, which will look at ranking a large number of interventions and also allowed us to assess the magnitude of the difference in benefit between those interventions. Actually, the net health benefits reflects its impact on total population health, net of any health opportunity cost, which was quite important in this study. So that's exactly what we did. So we looked at it, and then in terms of the health opportunity cost, we based on the study done by Kochlag and Co in 2018. That came out to a lot of net opportunity costs in a couple of low middle income countries. Next slide. So basically, a graphical view for our audience when you talk opportunity cost, definitely there's something, a price to pay for any decision we make. And that's why we felt that bringing him on board the health opportunity cost is quite important. That bringing anybody in, somebody goes out. So there's a price to pay. So this is about the whole concept, one in, one out. And we also look carefully at each other was done by just cultural, like I said. And we realized a lot of low middle income countries were based on this 1 to 3 times GDP. That was postulated by WHO those days based on the Commission on Macroeconomics and Health reports in 2001. So, but clearly looking at the data and work that was done and reviewing it, clearly in a lot of instances, what was calculated looking at it in terms of opportunity cost was lesser than what was stipulated by the WHO. And it even comes out the same way even in the high income countries. In the US, it's about $50,000 per dollars. But with the study, I think Clarkson and Co. They realized that it was within a range of $24,000 to about $40,000 per quality. It was also in terms of lower. So definitely there were some population health benefits that we're not gaining by relying on some of these data metrics. Next slide. So I think I've talked about it a bit. Let's move on to the next slide. So based on all this, we looked at all the analysis and we looked at so in terms of maximizing our health benefits, we include ongoing discussion on primary care interventions. We also focus on primary care interventions and had a component for co-insurance components for part of the interventions. So like I said, net health benefits is a measure of cost effectiveness. Next slide. Next slide, please. So in terms of maximum number of health interventions, we looked at the current status quo where implicitly we are looking at 95% of conditions covered. And then we look at the primary care interventions, which was reviewed by the Presidential Commission report in 2016. And then we look at a scenario where we are introducing some level of co-insurance for coverage beyond the basic package recommended by the Presidential Committee. Next, please. So in terms of our findings, I think one of the keys to the intervention with the highest net health benefits were things like somewhere in the high level range in terms of emergency obstetric, emergency neonatal care, which was beyond primary healthcare level, but had highest net health benefits. And then we also had our use of insecticide treated nets repair, drug treatment for childhood pneumonia, antivenom for snake bites, and a few others as you can see. Next slide. So emergency obstetric, like I said, and emergency neonatal care were found to have high net health benefits. And some of this had negative health benefits. In fact, for a lot of our mental health conditions, they have negative health benefits. But if you unpack the data carefully, a lot of the costs, how to do drug treatment, the drugs for schizophrenia, bipolar disorders. So if something was done around drug pricing, it could turn it over. And then our non-communicable disease really also had a lot of negative health benefits, our breast cancer treatment, cervical cancer treatment. So there were also issues about looking more at prevention in terms of this, in contrast with clinical management. Next slide. So in terms of implementation costs, it was about our current budget estimates that we receive as a sector. And it also excludes interventions like TB and HIV, which are normally funded through the Global Fund programs. Next slide. So looking at the scenarios, we looked at co-insurance, co-benefits, and also the maximized net health benefit. There were no co-payments, we had 100% coverage. And then we could also look at high number of interventions. But what I want to highlight is that a lot of our primary care interventions had maximum net health benefits. But the issue then will have to do with high emergency high net health benefits.
We've
Yes, so we can skip this one. Let's move to the next one. Yes, let's go to the next slide, please. Yes. So I think I've mentioned this in different ways. Let's move on to the next slide. During the Q&A, we can talk a bit more about this. Next slide. Okay, next slide. So basically the point I want to make is that we should focus on looking more at the population coverage. Ghana's system is more about intervention coverage. We need to look more at population coverage to maximize the benefits. Given our current budget, it's unlikely that we can cover our primary care interventions. And we also need to consider ways of increasing financial resources beyond our national insurance scheme. And in terms of disease conditions beyond the primary health care, we need to focus more on emergency obstetric and emergency neonatal care as part of our primary care package. And look at introducing some co-insurance for some subsets of interventions that offer prospects. However, we will require further research in unpacking a bit more of these things going forward. Next slide. We need to increase policy focus on preventing NCDs. As I mentioned, NCDs clearly will show not to be cost effective clinically, but we could do more in terms of prevention. And we also need to institutionalize HTA so that in real time we can review some of these things as we move on in terms of instead of doing it on an ad hoc basis, but there will be a system in terms of looking at cost effectiveness, especially looking at it from an opportunity cost perspective. Next slide. Okay. So at this point, I want to say, so we're looking at the HTA institutionalization and also having a system to monitor in real time. Thank you, and over. We'll handle most of the questions when we get to the Q&A with any other things that may come up. Thank you.
Fantastic. Thank you so much, Dr. Odame. That was a great overview, and I think we're going to have plenty of questions in the Q&A following that. So next, before I hand it over to Dr. Gongora Salazar, let me just reintroduce her because I got a couple of the elements there wrong, so sorry. So she has actually completed her DPhil, and she is now Senior Health Associate at the Inter-American Development Bank, which is based in Washington, D.C., and so she's joining us quite early in the morning from there. So thank you very much for joining us this morning, and I'll hand it over to you now.
Jessica, thank you so much. I'm just trying to share my slide. I don't know if you can see it, but I think it's not in presentation mode.
Yes, we've got it in presenter mode. So I think if you can switch it to view mode.
Just give me a second because I got it right when we were preparing.
It's always tricky, isn't it?
I know. The moment that you have to share it and it has to happen, it doesn't go exactly how you plan. Just a minute. Is that now right?
That is right. Fantastic.
Great. Thank you so much. Thank you, Jessica, and thank you everyone again for the invitation to join this webinar. I'm going to talk a little bit about the experience that we have had at the Inter-American Development Bank supporting Honduras and Argentina on the designer update of their health benefits package. I think this parallel between the two countries, which happen to be very different, it's an interesting one, and just to show how we approach in each country to the problem or the dilemma of how to prioritize and design a health benefits package. Just before starting, I just want to acknowledge that behind this work, there is a lot of people. Here are the main ones that have been working on this project, including the Ministries of Health of each one of the countries. And there are even more people, including you, Jessica, that at some point you supported us when we were starting the Honduras project. So to all of them, thank you very much. I would like to start with one question to all of you, just to warm up. And I would like to know, and I think you will see displayed the question in Zoom. What do you think is the greatest challenge in applying cost-effectiveness analysis for designing health benefits package in low-middle-income countries? You will see that different seven options for you to choose. So if you can share this your thoughts with us. And of course, feel free to also share your thoughts in the chat, especially if you think that none of the options here displayed happens to be the answer. And I let Francis or Jessica to decide when we close the poll, because I know that we are a little bit constrained in terms of time. So it could be the availability and quality of local cost data. It could be using local data to use economic evaluation from other, using local data. Sorry, this is actually the second one is, I got it wrong, but it's basically using economic evaluation from other jurisdictions. The third one, convincing stakeholders on the relevance of cost effectiveness criterion, balancing cost effectiveness with other criteria like equity or financial protection, or ensuring local capacities to ensure that cost effectiveness evidence is systematically used. You can also say that you're attending this webinar to figure this out, or you can also, suggest another answer. Oh, availability and quality of local cost data. Nice. The second one seems to be balancing cost effectiveness with other criteria. Okay. But I think the answer is, sadly, I don't have it. I think it could be basically all of them, and including I'm attending this webinar to figure this out. I'm attending the webinar myself also to, learn from other experiences, and I guess it also depends on the context. But now let's move and let me tell you about the experience in Argentina and do this. These three documents that I just wanted to highlight them. Among other sources, to make decisions on most of the methodological decisions that we ended up making when designing the health benefits package. And I'm going to be referring a little bit more in detail to this technical note developed by Pichar Riviere and Michael Drummond and others, a note that we published at the Inter-American Development Bank in 2021. So for Honduras, just as a little bit of a background, this is a country that is a low middle income country. It has a very high levels of poverty as well as inequality. As you can see from the Global Burden of Disease, the most recent one published by IHME, non-communicable diseases at the top, but we still have non-neonatal disorders as one of the top 5 causes of death and disability combined. Out-of-pocket spending in the country is quite high, 52%. I have to say it's one of the highest in Latin America and the Caribbean. It's also a fragmented health system in which, and I'm going to be referring mostly to the exercise that we have done with Vassall, which is the name of the Ministry of Health, who are basically providing for about 70% of the population, but it is estimated that only 50% have actually some access to health services. In terms of universal health coverage, the country has been doing, like some progress, but this is still, behind the average of Latin America and the Caribbean. So we started the design of the health benefits package with setting the fundamentals. So that's and here is just a summary of some of the main fundamentals, which is basically the aim and the scope. And I'm highlighting this because sadly, this is a topic that we don't spend enough time on. And it happens to be not only the roadmap for, the design of the health benefits package, but also for the implementation. And this is what we are observing right now when we are working on the implementation of the Honduras health benefits package. So as you can see, it's also, like the aim is basically encompassing the definition of universal health coverage, which is not surprising. And it happens to be a health benefits package that is aiming or targeting essential health interventions through the life course. And they're covering, at the beginning, they were trying to cover both primary and secondary health services. What was the prioritization approach that we use here? Well, at the beginning, when we were doing this exercise in 2019, 2020, just before COVID, actually. So we set, with the country, we decided on 3 criteria to prioritize interventions. Value for money, which is efficiency, operationalized through cost effectiveness. Equity, operationalized through the Sustainable Development Goals, due to the lack of data, and financial risk protection, in which we use a similar approach used by the Disease Control Priorities Project, which they also propose a health benefits package for low middle income countries, and it's based on a composed index. I'm not going to focus on this too because we don't have much time, but I just want to highlight what we did for the value for money criterion, in which we were basically identifying for a group of or universe of interventions that were candidates for inclusion on the health benefits package. We basically rely on the literature, mostly on information from the DCP3 study, HIP tool, which is a tool developed by the University College London, and the cost effectiveness registry from the Tufts University, and identify ICERs for each intervention. We chose the most appropriate ICER based on expert opinion, and this was based on like the characteristic of the intervention, the context, or the jurisdiction. Something we're looking for something closer to Honduras context, and of course the cost. And then we compare the ICER with thresholds based on what has been reported by the literature. Honduras hasn't estimated the cost benefit, the cost effectiveness thresholds themselves. So we basically rely on the stats from the literature. At the moment, we are actually in the process of adjusting this and updating this. And this is because COVID was in the middle. And sadly, we didn't have the time to complete all the validations with the different stakeholders. And now, of course, data has changed, the country has changed. So we are adjusting these indicators a little bit. And for the cost effectiveness analysis, we're using a similar approach. And this is being led by Professor Dr. Emmanuel Espinosa, who maybe some of you know. And we're again, setting some, cutoff points based on thresholds estimated by the literature, and classifying the interventions across these 4 groups: highly cost-effective, medium cost-effective, low cost-effective, and non-cost-effective. More importantly, now the ICERs are being chosen based not only on the intervention, but we are more carefully, taking into account the comparator, the cost discount rate, the study timeline, the outcome, and model that is being used. So, and then we are applying a decision rule for ranking the interventions. So the ones that are going to come first are those that rank high in terms of cost effectiveness, equity, and financial protection. And then we are prioritizing cost effectiveness and equity, followed by financial protection. For Argentina, it's a high middle income country. You can see based on the global burden of disease that, again, non-communicable diseases, as like in most of the countries, are at the top. However, and neonatal disorders is not the top 5, but it's the top 10, despite the improvement that we have seen over the years. The country, the out-of-pocket spending is not as high as in Honduras, but it's still above the the 20% that is and quite higher if we compare it with. And in terms of universal health coverage index, the country has made important improvements, but still below OECD countries. And it's also a very highly fragmented system. I think I would need an entire presentation to explain the health system in Argentina. But just to say that the health benefits package was also seen as a way to reduce this fragmentation in the system. These are part of the fundamentals, or some of the elements of the fundamentals that were set. As you can see, the scope relative to Honduras was greater or broader, because they were also including palliative care. And unlike if we compare it also with Honduras, they are not including population health interventions, and Honduras did. And again, the definition of the aim that we're pursuing, it's pretty much aligned with the universal health coverage definition, right? So in terms of the structure, it's also a little bit more complex, because it's a little bit more benefits package. Here we are first identifying the health conditions that we want to prioritize. Then within each one of the health conditions, we identify the pathways. So for instance, diabetes, there's one pathway for diabetes type 1, another one for diabetes type 2. And within each one of the pathways, we're identifying the services, the interventions, or the benefits. There are many names that we can use. And of course, for each one of the benefits, we are defining, whether it corresponds to prevention or treatment, and then which population are we targeting, and where these services are being offered to the population. For the prioritization of the interventions, to decide the contents of the health benefits package, we followed a stepwise approach. So first of all, we conducted a multi-criteria decision analysis with members of the CONITEC, which are basically the commission in charge of health technology assessment, to rank the different health conditions according to 4 criteria: burden of disease, inequity in access, severity, and size of the benefit. And we used, I mean, there are many, there are many methodological approaches that can be used. Here we use a pairwise comparison that is called Paprika to define or to set the relative weights for the 4 criteria. Once we have ranked the health conditions, we identify the care pathways that I showed you here before. And this was done based on extensive review of clinical pathways and meetings and roundtables with clinicians from the country. And then we prioritize health interventions following basically 3 steps. We first identify the universe of interventions which within each one of the care pathways. And then we adopted a triage approach, so to speak, in which interventions were classified into 3 groups. And I'm going to show you this more in detail in this graph, that it's actually my favorite one. And so there's some, I mean, what we figured out is we got to be pragmatic, because, you know, we always face time constraints, data constraints, and we got to be efficient as well on the cost effectiveness or on the prioritization of health interventions. So there are some interventions, you know, like that we all know that they are, you know, like are very likely to be highly cost effective, and you know the country is already providing coverage to this intervention. So those are the ones that we classified as the yes. There's, you know, like effectiveness of these interventions is proven. They already, you know, like highly recommended in clinical guidelines. So there is no reason for us to, you know, like conduct additional studies or evaluations. There are, however, some interventions that happen to, you know, like there is not much evidence on the added value, and there is a high probability of not being cost effective. So for instance, if, you know, like the UK is not offering this a certain intervention in the health benefits package, or, you know, they don't have a health benefits package covering this intervention, nor in Canada, nor in the UK, why should Argentina, which is a, you know, less developed country or with the lowest income, why should they cover it? You know, like it is very unlikely that it's going to be cost effective. And, you know, like you can see here, the cost effectiveness threshold for Argentina per quality is about $9,000. And if, for instance, here we have some examples in which the continuous insulin infusion, the ISO was, you know, like quite a, the ISO is quite high. It's actually, it can be actually greater than $30,000. So, you know, like it's not really cost effective for the country. Now, the tricky one is the gray area, in which, you know, we have interventions that we're not certain whether they can be a yes or no. So for those interventions, we adopted, or we rely on adaptive health technology assessment. And that was the case of the GLP agnostic, which is for the treatment of diabetes 2. And this is what the flow chart that we follow when conducting the adaptive HTA approach. So if we review economic evidence, and it was suggested for inclusion if, according to the economic evidence that we reviewed, the cost effectiveness, the intervention was considered to be cost effective based on international data, and there was no significant variability across cost effectiveness studies. So that was a sort of an easy in. Easy out is if it is not cost effective based on international data, and there is no or little variability across cost effectiveness studies. So, so basically it's an easy out. We are not considering or not suggesting this for inclusion. Now, if there is a reasonable doubt, then we use PICO, and then to match or to identify which study is the one that we should rely on to make our decision. And then if we find another, you know, like a good match, then we adjust the ISER to the local context using like what is called a crude extrapolation of the cost effectiveness of economic evaluation. And this is based on the prices, basically. And this is what you can find in the first technical note that I presented at the beginning of the presentation. Now, if there is no study that matches well, then we consider this intervention for conducting a complete health technology assessment. And that was also the case when there was no evidence, and we consider the intervention still to be important to be assessed for consideration for the inclusion in the health benefits package. So some takeaway points to finalize. Well, cost effectiveness considerations are crucial when designing health benefits package, potentially the most important one in low middle income countries. And it could also be important not only from a methodological and, like a opportunity cost point of view, but it's also from a political point of view. We notice that when, like policymakers or decision makers grasp the concept, they were even defending themselves the use of a health benefits package and understanding, like why in the end we have to say no to some interventions. Designing a health benefits package also requires key information and data elements, many of which are not available locally, especially in low middle income countries. So using economic evidence from other jurisdictions, it's like an answer. We have found it as an answer. It's pragmatic. It can also be efficient especially when uncertainty and budget impact are relatively low. Importantly, however, is the local unit cost, in which like this is something that we cannot really rely on international data, or at least that we shouldn't, or we should try to do it as less as possible. And it also, the costing, I didn't have the opportunity to explain this more in detail, but for us, the costing was crucial. Not only because of, like informing also the cost effectiveness analysis and like telling the country how much is this going to cost and comparing and conducting budget impact analysis, but also because it was allowing us to show, like how big the gap was and how much the country would need to invest to close that gap. And that was, crucial information when we were discussing, especially with the finance ministers, and like advocating for extra funds for the health sector. Now,
Pamela, we've gone over 15 minutes, so if I could ask you to very quickly wrap up.
Yeah, sorry, thank you. So just to finalize, many countries are relying on adaptive HTA methods, but there's still a need for guidelines and standardized best practices. There are many questions that we haven't answered, and I think it is important that academia and policymakers address these questions together. And also, I have to say that, especially in the Argentina study, we have figured that there's a lack of studies of cost effectiveness study analysis on NCDs for low middle income countries. And again, I don't think there is a recipe, like a unique recipe, like there are many different approaches, many decision rules, different criteria, different analysis to be conducted, and it depends on, like local capabilities, making sure that the approach that is used is sustainable, that we consider the time constraints, data availability, and so forth. Just to finalize, this is a commentary that we recently wrote with Ursula Guidon, Emmanuel Espinosa, Odame, HITAP, and Dan Allendorf. If you guys have the chance to have a look, in which we discuss this more in detail. And if you want to know more about the Honduras experience and the Argentina experience, there's a technical note that policy brief that we published a couple of years ago, and then Argentina recently published this, sadly in Spanish, but we will do it in English soon. Thank you very much. And apologies for taking more time than expected.
Oh, thank you very much. That was a really interesting comparison of Honduras and Argentina. So I'll hand it over now to our final speaker, Sakshi Mohan.
Great, thanks, Jessica. If you could just let me know if you can see the presentation.
Pamela, I think I still see your slides. Are you able to stop sharing, please?
I don't see how can I stop seeing it, to be honest. Oh, no, I saw it. I found it.
Thank you.
Sorry.
No problem. Okay.
It's okay. Can I check if you can see this now?
Yep, that looks perfect. Thanks.
Great, thanks, Jessica. So good morning or good afternoon, everyone. I will be speaking about the economic analysis that fed into the health benefits package design in Uganda, and specifically the application of constrained optimization in order to guide prioritization of services. So what I'll present draws on very similar elements to what the previous speakers spoke about in the prioritization of services, but the methodology is just slightly updated to focus more on resource constraints. So as the previous speakers have highlighted, there's often a considerable gap between aspirational health plans of low and middle income countries and their available resources. This is where the use of cost effectiveness thresholds, or this idea of health opportunity costs, comes in, which allows countries to incorporate resource constraints in their prioritization decisions to kind of bridge this gap between aspiration and feasibility. However, using a cost effectiveness threshold alone does not ensure feasibility, because it assumes, firstly, a perfect divisibility of resources because it assumes this kind of overall budget constraint, and also cost effectiveness thresholds are endogenous to the decisions that you're making. Dr. Odame spoke about this bookshelf approach, which allows for the incorporation of a single resource constraint, such as an overall budget constraint. So this figure from Ohalik et al. Tried to sort of line up interventions in a decreasing order of their health to cost ratio. And then interventions were included in the package for Malawi in this case, up until the drugs and commodities budget was exhausted. The problem with this approach is that only a single constraint can be incorporated. And as we know, in the short to medium term, the overall budget is not perfectly fungible. This means that there are certain resources that are sticky in the short to medium term, such as human resources, which can't just be expanded instantly. And so the constraint optimization method allows for the incorporation of multiple constraints in the choice of interventions. Just to set the context, we're working with Uganda, and at the time of the analysis, the population was about 44 million. The current health expenditure per capita was $36.9. And the government expenditure as well as donor expenditure together constituted a majority of the healthcare expenditure in the country. And the life expectancy of the population is about 62.9 years. Importantly, there is a huge problem of human resource shortage in the country. So these are just some figures from the National Health Workforce accounts. And what we see here is that overall, the density of health workers per 10,000 population is half of the global median. And so this is what we wanted to focus on addressing through our prioritization of services. Now, without going into the technical details of it, this essentially represents the constraint optimization framework that we set up. But very briefly, the framework tries to find the optimal set of interventions in order to maximize the total value that is generated by the selected level of coverage of interventions. And we try to maximize this within certain constraints. And we included the drugs and commodities budget constraint, as well as the health worker capacity. This was measured in terms of the patient-facing time that was available in the country. Now, going back to how the value was defined in the objective function, like the previous, like Dr. Odame's study, we used the net health impact, which, as previously mentioned, is just the disability adjusted life years averted, less the health opportunity cost of alternative uses of that money. So as you can see here, you have the familiar equation of net DALYs averted of any intervention I is just DALYs averted of that intervention by that intervention I minus the cost of the intervention divided by the cost effectiveness threshold. I also wanted to emphasize why we needed to account for the cost effectiveness threshold within this analysis. Now, in the ideal case, if you're applying constrained optimization and you're able to capture all the possible supply and demand side constraints in the health system over the relevant decision time frame, then we don't actually need to account for a cost effectiveness threshold, because all of those individual constraints will capture what the CET is trying to capture. And the objective in this case would simply be to maximize the gross health benefit of a package of interventions instead of the net health benefit. In reality, as you're all aware, it is difficult to capture all constraints. Our framework, for example, only captured two supply side constraints, namely the drugs and commodities budget and the health worker capacity. And so incorporating the cost effectiveness threshold does two things. Firstly, it allows us to encapsulate these sort of other constraints on which we either didn't have data or not enough knowledge to understand which other constraints should be part of this decision-making process. But also it helps us factor in any downstream costs. So this has to do with the fact that our constraints only captured constraints at the annual scale. So all the drugs and commodities budget, as well as the health worker capacity, was applied for 1 year, whereas there are obviously downstream costs to providing an intervention, which are captured within cost effectiveness studies. So accounting for this cost effectiveness threshold allows us to incorporate those downstream costs as well. Again, I won't go into too much detail here, but this is the list of inputs that we used in the analysis, starting from the cost effectiveness evidence for the objective function, as well as the size of the eligible population for each intervention. And on the constraint side, we have the cost effectiveness threshold, and we used an estimate from Lomas et al. 2021, which gave us an estimate of $161 per DALI averted for Uganda. And then we incorporate consumables cost, health worker time required, as well as on the right-hand side of the equation for constraints, the total consumables budget and the health worker capacity. So moving on to the results, we were able to run the analysis on a total of 125 interventions on which we obtained all the data that we needed. So if just to show you what this looks like, if we were to apply no constraints to the system, we would end up with 118 interventions in the package. This is just removing any substitutes that were within the list of 125. But what we see is that including all of these interventions would firstly lead to a negative net DALIs averted, as well as it would far exceed the resources available in the health system. The drug budget, for example, would be exceeded by 216%, or in other words, 316% of the drug budget is needed to deliver all of these interventions, and so on for the health workforce capacity. So at the next stage of the analysis, we incorporate the drug budget. And as expected, now we have a smaller package of 76 interventions. We are within the drug budget and we use all of it. But even in this scenario, the health workforce capacity is exceeded. And so now we're able to incorporate additionally the human resource capacity in Uganda. And what we arrive at is a much smaller package of 45 interventions. We're using all of the pharmaceutical staff and nutrition staff capacity, and it appears that these are the binding constraints to the system because, in fact, we're not fully utilizing the drug budget, the clinical staff capacity, or the nursing staff capacity. We therefore ran one other scenario, acknowledging that there is some task shifting that takes place in constrained environments between pharmacists and nurses. That is, other cadres are able to dispense drugs when pharmacists are not available. And so we have this with task shifting scenario where we have 73 interventions. The system is averting 32 million net DALIs, and we're now using the resources available much more fully. So just because I wouldn't have time to go through the full list of interventions, I've just summarized what the composition of the package looks like. Most of the interventions in the package, as you can see, are very cost-effective RMNCH interventions, and then followed by HIV, NCDs, and then malaria. Just very quickly, another application of this analysis is that we can understand what's the net health impact of relaxing any of the constraints in the framework. And in Uganda, we found that the net health benefit of investing in human resources was greater than that of investing in the consumables budget. Again, I won't go into too much detail here, but happy to discuss this during the discussion session after the presentations. Again, quickly on the limitations, just as the previous speakers have mentioned, this is a data-intensive approach, which is why it's very difficult to account for all possible interventions that countries can look at in this analysis. The quality of the results obviously depends on the quality of input data. All of the inputs were based on secondary sources. So the results are as good as the cost effectiveness evidence, the threshold estimate, and the resource requirement data that we have. We also assume independence between interventions, which just means that there's no interaction between either the conditions or the treatment effects of interventions. And finally, we assume a linear production function, so economies of scope or scale are not included. I'll just end by saying that any economic analysis is just one input into the decision-making process. So our results were provided to the government of Uganda, and then they had a deliberative process which led to the finalization of their list of interventions. So yeah, thank you so much, and I look forward to the discussion.
Thank you, Sakshi. That was really interesting. Got quite a lot of information into that 10 minutes, so fantastic. I will now hand it over to our discussant, Professor Anna Vassall.
Hi, I haven't got any slides. I'm just going to sort of speak, if that's okay. So first of all, I really liked all these presentations. I think probably much of the audience and ourselves, we have these kind of complex data concepts in our head, but all these examples were real world examples where I see that people have tried to problem solve in a creative way, sort of keeping that all in mind, but in the end, sort of facing a very real data constraint and probably in terms of time constraint as well within countries. So I think these were all excellent examples of people grappling with all those things simultaneously and actually coming out with really interesting analyses and useful results. So just to congratulate you all on this. I love this stuff. It's like we're all doing it. We're all figuring our way through. It's not like there's people pointed to resources, but it's not like there's a manual, and it's really good to have these webinars where you get to see the different ways people are trying to do this stuff. I'm gonna focus on one part of it because that's the title of this seminar. So there was lots of interesting stuff there. I'm really just going to focus on this title of using opportunity cost thresholds in health benefit package work. And that's quite interesting because as far as I understand, and Jessica knows better than me, but this all came out very much of a need in the UK for incremental cost effectiveness analysis and really trying to understand when you're making a decision at the margin, how should you be grappling with whether that's an efficient, how you're going to assess efficiency in that situation. And yet here, we're seeing that same sort of understanding being applied to situations where either it's a whole sector or a big chunk of the sector. And it was nice to put scientifically, like the thresholds are endogenous, I think was said in the last presentation, but there is an issue there that thresholds shift depending on what is at the margin at that time. So just generally, I think this is an interesting webinar because people have decided to use those thresholds designed for an incremental analysis in different ways in these processes. So you see, like in Ghana, is actually used in the calculation, the net health benefit calculation, to try and show people instantly rather than in different kind of metrics together of what is the potential impact on population health. And I find that really useful because I think there's a danger when we used cost effectiveness in these kind of processes, especially with many non-economists involved, that we're always seen as cost cutting, and it's not really understood. What we're trying to do is improve population health, that we're with them. We're with the objective of everyone in the room, but somehow the name of our metric, so this kind of net health benefit, I think is probably designed not because it's particularly easy to understand, but because it draws attention to the fact that that's what we're doing. I'm very curious in Ghana because it does require a certain sort of shifting round in the head of the metric and understanding how a threshold works and how it's in that calculation. So I'm very curious, in the Ghana example, is how it understood the use of a threshold in that calculation was, rather than as something you have cost effectiveness and you compare to a threshold. And then that's kind of an easier thing for a decision maker to understand. So that's a very interesting use. I think in the second case, what you saw was using it more directly like that, but using it quite concretely in a set of decision rules. And also, interestingly, at the end, I'm not sure I quite understood, but I think it's used in the same way that I've often used it in terms of a kind of scoping decision of saying, well, actually, if it's really clearly cost effective, we can make a decision where it's really clearly not. But if somehow it's sort of near the threshold, then maybe that is a kind of marginal decision, and maybe we need more evidence or a strength in evidence or precision there, because otherwise we may actually make a wrong decision here. So I see it was kind of two uses there, which was kind of, I think for me, the latter use was particularly interesting. And in the last use, yes, very clearly as part of one constraining factor. So it's really, for me, that was fascinating, because it's something which conceptually we all sort of, some of us at least, quite like as economists, but used in a way that perhaps it wasn't originally intended. So that's my first observation. And I'm quite interested to hear people's reflections on that. I think in terms of Ghana, I had this sort of question, and it's only a question, and it was pulled up. When we have that kind of bookshelf thing, and we have at the end the budget constraint, then in a sense that reveals the new threshold, or in a sense a budget constraint would be sufficient. Let's just optimize within that budget constraint, especially when it's a very large package, almost sector-wide. So I was quite, we've done work in other countries where we tried to say, well, look, this is the threshold estimated by people like Jessica. And how does it actually, you know, when you look at current allocation, actually, and what we know about current coverage and cost effectiveness, are we sort of hitting the same level? Or when we look at the current allocation and doing it in that very detailed way, is actually the intervention currently at the margin sort of matching what the other work across countries is predicting, or not predicting is the wrong word, but is estimating would be at that margin. And I'm not sure if that was looked at in Ghana, but if it was, I'd be really interested. When we did that comparison in Pakistan, it actually wasn't too far out of the 0.5 GDP type style estimates. It was quite interesting when we looked at current allocations. We thought actually those marginal interventions are looking at that kind of level. Not everything, obviously we had some very high non-cost effective stuff sort of muddled in there as well, but broadly it sort of made sense. So that's something interesting, I think, in Ghana, whether we should be checking that, and maybe there's opportunities to check that as we go forward in this area. I think in the sort of case of Honduras and Argentina, I liked your decision frame using it. I was quite interested why in other countries what you see is possibly cost effectiveness is first, but then traded off with the other criteria. And I never know quite what to do, but in terms of something being high, you know, there's the other sort of decision rules where you could say, well, it's definitely in if it's high, because that's so clear, and the trade-off with the other items is so high. So I'm just curious of your use and that labeling of high, medium, and low, and how you sort of decided what that was, and how you, I don't know, for me, the way you decide the high, medium, and low is not empirically, is about the consequential, I suppose the point I'm trying to make is the consequential decision from it. So you would define something as high in the sense that if it's high, I would, you know, provisionally recommend this unless X, Y, and Z. If it's medium, what I would hope would be done would be that discussion about trade-off. If it's low, you have to have a very, very good reason for accepting this, because the cost in terms of population health is going to be very, very high. So I was just interested in how you define those cutoffs, and whether it was sort of some empirical basis, or whether it was actually to lead to it, related to a decision you hope would be taken, or discussion you hope would be made. So that was quite interesting. And as I say, I talked about this, the idea of using it for scoping, which is something I've done and I think is a really useful use of this. In the last presentation, in terms of constraints, I mean, I really, really liked that approach. It was, to me, really transparent. Even you presented it really clearly, but actually, even when I just saw the slides, I could see the slides. I could see what you were doing. Okay, there was the equation part in there, but basically the tables were very clear. I like this layer approach. What I really, really like there is not that these constraints are seen as something which happens post-prioritization, which I think is quite common, that, you know, we do this prioritization exercise without considering those things. Then someone has to write the budget, and someone has to plan the human resources, and then suddenly doesn't fit, and we don't implement that prioritization consideration. So the more we can bring constraints into it, not necessarily just simply as a feasibility criteria, but in these other ways, quantitatively, I think is really interesting. I know that there are other approaches in terms of being more opportunity cost related, of saying, well, actually, using your scarce human resources has a much higher opportunity cost than others. So I'm curious, I like those approaches theoretically, but your approach was much more practical. So I'm just curious how you felt about that, why you didn't consider some of those other approaches, which says actually you try and figure out the higher opportunity cost. And you kind of do at the end, you try and look at the marginal benefits, but just like why? I mean, I really liked it, so I don't really have any critique. I'm just trying to relate it back to other work done on opportunity costs of it. I actually prefer the approach you took, to be frank, but it's just that there is these other approaches where you actually work out that kind of threshold for these other resources too. So I think I know we've only got 10 minutes of discussion, so I'm just going to leave it there. You can respond, or Jessica, over to you. Maybe there's audience questions as well, but I hope you saw. Thank you.
Thank you very much, Anna. Those are some great questions to start with. So the audience is quite quiet at the moment, so I think let's get the ball rolling with those. Do we want to take them sort of in the order in which they came? So Dr. Odame, if you wanted to respond first, or if you want to hand it off, happy for you to take the lead.
Yeah. Thank you, Jessica, and thank you, Prof. Vassall. I think we've really brought to the fore a lot of very intriguing conversations, and for me, I even see work that we can carry forward. Like I said in the presentation, for Ghana, we realized that there was quite a lot of data gaps, and that's why finally we could focus on 69 interventions. So, like I said, the bookshelf approach, the optimization, we didn't go to that last level where we're looking at it in terms of the GDP per capita, 1 to 3 times. But some initial work I've done shows clearly that it might be less. So there might be a lot of population health loss benefits in terms of what we are currently doing in terms of based on those WHO thresholds. And I think it calls for a deeper look and some further research, really. A lot of interventions, because it means along the line, we're losing a lot of population health benefits. And even if when I compare across high income countries where the thresholds, I think the US it was $50,000. And if I'm not mistaken, the UK it was about 20 to 30,000 pounds, based on the work I think done by Carl Claxton and co. Clearly, a lot of work has shown that they realized that it was a bit lower, even compared to the US thresholds, which was about $24,000 to about $40,000, based on a study that Carl Claxton did. So I think this calls for further research, really, especially in low middle income countries, to really explore a bit more further on this. So I'm really grateful for bringing this up. Thank you.
Thanks, Dr. Odame. Of course, I have loads to say, but I am not presenting or discussing, so I'm the chair. So I'm going to hold off, and I will pass this on to Pamela, if you had anything to say in response to Anna's points.
Thank you, Jessica. Thank you, Anna, for the question. Well, the reason that, or the way that we set up these thresholds is because there are different estimates in the literature, and the reality is that we don't know which one is the right one, right? And so we're basically, like we decided to use this approach as a way to be more cautious and to, make sure that at the beginning or the start, we were prioritizing the most cost-effective one, like the one with the lowest opportunity cost. So that's basically the way that we did it. And in the revision that we are doing at the moment is because when we were, like checking which interventions were at the beginning classified as not cost-effective, but like they were very close to the margin that we were setting, to the to the one of the thresholds that we were setting. That in discussions with the clinicians and with the country, we're checking also other studies from other countries. We're saying, okay, maybe this is like we're being too harsh with this one. So like let's disaggregate a little bit further and set additional categories, so to speak. I have to say that this discussion about the threshold deserves a webinar in itself, especially for low middle income countries. In Dominican Republic, for instance, we supported the country with the calculation or the estimation for their health benefits for their cost effectiveness threshold using local data. And the estimate is significantly low than what other papers report, especially the ones from the Lancet. And now we are facing discussions, and I can also let you imagine pressures from the industry. So, you know, like it's a tricky decision, and I think that's also something to acknowledge, you know, like the variability and also the confidence intervals in these estimates can be very broad.
Fantastic. So actually for the first and second webinars in this series, they were on the topic of cost effectiveness thresholds and how to estimate these. So I will either myself or Francis from HITAP will post in the Q&A so that folks can have the link to those because they're available on YouTube now. But I absolutely agree. I mean, the discussion on that could go on and on. So just because we're short on time, I'll pass this over to you, Sakshi, if you have anything in response as well.
Thanks, Jessica, and thanks, Anna, for the great points. So I'll just respond to the question that was posed directly to me on this idea of should we prioritize based on the constraints, or should we plan for for health assistance based on the interventions we prioritize in this sort of chicken and egg problem. And I guess with Uganda, our rationale was that human resources are highly constrained, and that's well acknowledged within the Ministry of Health. And so if you had a package of interventions based on just the conception of opportunity cost, you would arrive at a place where, you know, your resource requirements would be higher, and the ministry could build into a strategic plan, you know, this higher human resource capacity as an objective. But that's not something that can be achieved within even the next 5 years, because especially human resource is a very sticky resource. It takes a long time to change. You have to enroll students, train them, recruit them, and then, you know, in-service training. So it's a long process. So that was very important for us. And but I think one of the problems with our approach is that we applied a very sort of theoretical estimate of how much time is actually needed to deliver every intervention. When I say theoretical, it was based on sort of time and motion studies in a different country, which we sort of you know, assumed would be very similar in Uganda. But that is kind of the ideal estimate of the time that is required to deliver an intervention. In reality, we know that health care appointments are squeezed. So, you know, doctors and clinical and nurses are delivering interventions much faster than, you know, what the ideal case would be. In our analysis, we're not accounting for that sort of real life scenario where a lot more is being delivered by the health workers than we think they should be delivering. So that's something, you know, to think about. And just on your first question on sort of, you know, whether the analysis led to, you know, us figuring out what the threshold or what's the intervention with the highest cost to health ratio, essentially. So for our framework, we applied a threshold of $161 per DALI averted, and the least cost-effective intervention in the package was $122 per DALI averted, which it's subjective opinion whether that's close to the threshold or not. But I would say it's still, you know, it's still within the threshold, which means that the threshold is still a good upper limit to have set out in the analysis. Yes, I'll hand over back to you, Jessica.
Thanks. Yeah, I wanted to add exactly to that point about what is the marginal intervention. Are these thresholds really representative of opportunity cost? Based on work that we did in Malawi, which I think Dr. Odame also discussed a bit. So we included things up to sort of what we could up to the things that were the maximum estimate of cost effectiveness threshold. Then we costed them, and the budget that came out of that was effectively equal to the budget that was available, which was convenient, obviously. But does that answer the question of whether that meant that we had the right estimate? I'm not sure. I think it was in Malawi, it would have been very difficult to answer that question because we didn't have data on all of the interventions and all of their costs and effects. Yes, so it is almost 1:15. So we've had one final question. We had a question directed about Argentina, which Pamela's kindly answered in the Q&A chat. And so we'll finish it with this last question, which is about the time frame of health delivery being much faster or longer in reality than it is in theory in Uganda. that, okay, so I don't see the question in that. Yeah, so I think, sorry, Sakshi, so you made a really good point about that, and that has also come up recently in discussion about how we cost these things, particularly when you're doing surveys to try and ascertain how long things take to feed into this kind of analysis. Like when people are being observed, they might not do it in the actual time that it takes, and then getting those estimates is quite challenging. Given so that now we're now at 1/4 past the hour, so we've got to unfortunately finish this webinar, but I wanted to thank all of our speakers and our discussant, Professor Vassall. This has been really interesting. It was fantastic to hear about how this has been done differently in all of these contexts and the different approaches to try and answer the same question. Yeah, so thank you all very much for your time, and thanks to everyone in the audience who came to attend this. I hope you enjoyed the webinar. Thank you.
Thank you. Bye-bye.
Yeah,
Thank you. Bye-bye.
Thank you. Thank you, Jessica. Thank you, Prof. Anna.